Hello and welcome. In this video clip, I want to look at antidepressants. Again, I wanted to serve as a brief introduction from which we can go over things perhaps in more detail in one-to-one supervision sessions. I also wish to give a slant towards antidepressants in primary care because the majority of you are training to be GPs. Again, it's helpful to think in terms of receptor activity, and the antidepressants then break down into your SSRIs, selective serotonin reuptake inhibitors, which, as the name suggests, are selective just for serotonin receptors and as a result have fewer side effects than other antidepressants that work on other receptors intentionally or coincidentally. You have your SNRIs, serotonin and noradrenaline reuptake inhibitors, such as venlafaxine and duloxetine. As the name suggests, they are selective for serotonin and noradrenaline, although it depends on the dose, which we will come back to. Your tricyclic antidepressants then work on a broader range of receptors, serotonin to a degree, but mainly noradrenaline, also dopamine. This is monoamine hypothesis of depression after all, and to a degree on H1 receptors and anticholinergics. You have your monoamine oxidase inhibitors, which are not much used anymore because of difficulties with toxicity, amongst other problems. Many would argue that is perhaps a slight oversight, but I'm not going to go into them in any detail. And you have the atypicals or odds and sods, mirtazapine, which, unlike monoamine oxidase inhibitors, you will see a good amount of mirtazapine being used. First point I want to make is effectiveness and efficacy. If you don't know the difference between effectiveness and efficacy, it's something we can look at in one-to-one sessions. The STAR-D trial a few years ago in America gives a good appraisal and assessment of effectiveness of SSRIs, particularly citalopram, because in that study the first treatment step was citalopram and remission rates were 28%. There were another 3 steps to the study, mainly involving antidepressants, but also including cognitive behavior therapy, and the results were frankly disappointing. After 4 different treatment trials, the remission rate for clinical depression in the STAR-D trial still had not gone beyond 55%. One point to emphasize at the outset is I consider it a good idea to reassure the patient that antidepressants are not addictive. It is an often unspoken question, and perhaps is part of the reason why antidepressants are not often complied with. One study in the States found that a large, substantial minority of patients for whom an antidepressant had been prescribed never collected the prescription. Although antidepressants are not addictive, it is important to tell the patient not to stop them abruptly without discussing it, particularly if the patient has been on the antidepressant for more than about 6 weeks, and particularly if they are on moderate or high doses, and we will come back to that. So, what antidepressants do you consider? Well, a treatment algorithm would be useful, although they have their criticisms for being a little bit reductionist, but a treatment algorithm would be a good place to start. And you would think that NICE would be a good place to look for a treatment algorithm. And there is an algorithm there, although it's rather limited. The current NICE guidelines on depression and treating depression are over 10 years old. They mainly focus on non-pharmacological interventions, and they have drafted new guidelines which are out for consultation at the moment, so we await the final version being agreed. NICE does make the very important and very useful point that antidepressants should not be used for mild depression. There is no evidence whatsoever that antidepressants work for mild depression, and why would you be using a medication which might confer side effects and is not going to confer any benefit? In mild depression, it recommends other non-pharmacological approaches such as behavioral activation, cognitive behavior therapy, interpersonal therapy. For moderate and severe depression, NICE say you should still use non-pharmacological approaches, but also consider using an antidepressant. And it does favour SSRIs in the first instance, and that is eminently reasonable. SSRIs are not toxic in overdose, as I've mentioned earlier, because they are selective for serotonin reuptake inhibition. They do not confer much in the way of side effects by comparison with other antidepressants that hit other receptors. And another advantage to them is the fact that the smallest tablet size is usually the minimum therapeutic dose. Smallest tablet size of sertraline is 50 milligrams, and that is the minimum therapeutic dose. With a tricyclic, such as, say, amitriptyline, the smallest tablet size is, I think, 10 milligrams if memory is working properly, but the minimum therapeutic dose of amitriptyline is 150 milligrams. And with the likes of tricyclics, you can easily waste the patient's time using sub-therapeutic doses for treating their depression. So for all those reasons, it's reasonable to start with an SSRI. So that's nice. Doesn't tell you much more than do not use an antidepressant if it's mild depression, and in moderate or severe, use other non-pharmacological approaches as well, and consider using an SSRI. But it doesn't really tell you much more than that. Where else might you look? Well, SCIAN, the Scottish Intercollegiate Network, that is a good resource. Ironically, I get the impression it's used more often outside of Scotland than it is within Scotland. It's not much help, though, with clinical depression, because there is an archived list of recommendations on non-pharmacological interventions for clinical depression, and a document with recommendations for treating postpartum depression, but there's nothing in SCIAN on treating clinical depression with medications outside of that. However, the guidelines from NHS Tayside include one on treating clinical depression in primary care, and it's not bad up to a point. It refers to NICE, so it encompasses that recommendation to not waste your patient's time using antidepressants if they're suffering from mild depression. And it goes on to say that if you're dealing with moderate or severe depression, as well as other interventions considering an antidepressant, then consider a generic SSRI in the first instance, and specifically mentions fluoxetine, sertraline, and citalopram. And it does draw your attention to the fact that fluoxetine has a very long half-life, and there are particular considerations with QTc prolongation with citalopram, which we will return to. It does allow you to switch from one SSRI to a different SSRI if the patient hasn't been able to tolerate the first SSRI. But if the patient has been able to tolerate one of those 3 SSRIs which it mentions for an adequate duration of time and has not responded, or their illness rather I should say, has not responded, then it suggests and recommends switching to a different class of antidepressants. But that's where it begins to fall down, because it doesn't actually name any other classes of any other class beside SSRI, and doesn't mention any medications by name from any other class apart from SSRI. So as I say, NHS Tayside guidelines for treating depression in primary care are good up to a point. They recommend only using antidepressants for moderate or severe depression, along with other interventions, and mention medications specifically for use in the first line, and they're all SSRIs. It suggests then changing to a different group of antidepressant if an SSRI hasn't worked, but doesn't tell you any more than that. So where do you go? Well, there is another treatment algorithm which is on the website for the Advanced Interventions Service, which is both local and national because it's a national service based locally. And the Advanced Interventions Service makes reference to NICE guidelines, which I've already covered, and then is more specific than NHS Tayside's recommendations for treating depression in primary care, in that it says first line, sertraline 200 milligrams or escitalopram 20 milligrams, and if your choice there doesn't work, then switch to a different group of antidepressant, and names venlafaxine at doses of 300 milligrams or more, or mirtazapine at 45 milligrams. So it is more specific there. It starts, as they all do, with an SSRI, and then recommends moving to a different group if an SSRI for an adequate dose for an adequate length of time hasn't changed, and does specify what you can switch to, venlafaxine or mirtazapine. So there are reasonable algorithms for starting. There are some special considerations that I will now go on to mention. I have referred already to my suggestion that you reassure the patient in the first instance that antidepressants are not addictive, but you should also mention to them the risk of discontinuation syndrome if they stop the antidepressant abruptly, particularly if they've been on it for a good few weeks, and especially if they have been at moderate or high dose. Now, discontinuation syndrome is not conferred by any addiction. You can reassure the patient. Discontinuation syndrome is caused by sensitive receptors suddenly finding themselves naked in a storm of neurotransmitters, and the risk of discontinuation syndrome is not just conferred by abruptly stopping it, but it also depends on the half-life of the antidepressant. Fluoxetine, as mentioned in NHS Tayside primary care guidelines, has a very long half-life, and it is difficult, if well nigh impossible, to cause a discontinuation syndrome by stopping fluoxetine. However, paroxetine has a very short half-life, and it is notorious for causing a discontinuation syndrome if it is stopped abruptly. And that's part of the reason, a large part of the reason, why you will not see much paroxetine in use. Symptoms of discontinuation syndrome include irritability, nausea, diaphoresis, paresthesia. For stopping antidepressants, there is a broad rule that if somebody has been on an antidepressant for years, then you stop it over months. And if somebody has been on an antidepressant for months, then you stop it over weeks. That leads me on then to swapping antidepressants, because both for stopping and for swapping, there are guidelines available, and your local friendly pharmacist will be able to help. And I'm not going to propose going into detail of each and every possible permutation of swapping, but cross-tapering is possible for a number of antidepressants, and there are guidelines available from that, not just from your local pharmacist, but also in David Taylor's Maudsley guideline. The up-to-date edition of this I have in Carsview, I assure you. Some other special considerations then. you will see the combination of venlafaxine and mirtazapine. It makes a lot of sense. Mirtazapine is quite different from all other antidepressants. It works on presynaptic and postsynaptic receptors, and the receptors that it works on pre and postsynaptically are different from the receptors that SSRIs and SNRIs work on. So you can see, therefore, once you look at it through the framework of receptor activity, why mirtazapine is eminently suitable for being combined with either venlafaxine or an SSRI. There are some other potentially helpful spin-offs from that. Mirtazapine working on H1 receptors will confer a hypnotic effect, which an SSRI or venlafaxine will not do. But of course, with that is a risk of metabolic symptoms, change in appetite, and increased weight. Mirtazapine, for reasons I don't propose to get into the detail of, but it's worth mentioning, can also ameliorate some of the side effects of venlafaxine. So for a number of reasons, the combination of mirtazapine and venlafaxine does make sense, or mirtazapine plus an SSRI. It is collapsed in NICE under combination antidepressants, and for combination antidepressants, NICE say they can be considered, but only once you've consulted with a specialist. Moving on to other particular considerations then. Sexual dysfunction as a side effect of medication, erectile dysfunction, anorgasmia. All psychiatric medications can cause such problems, especially antidepressants, and within the group of antidepressants, it's especially SSRIs. And it is a difficult one to get around apart from dose reduction, which doesn't always fix the problem. It is an iatrogenic problem, so you may find yourself recommending sildenafil for patients who have been afflicted, although that's of limited use for female patients who are afflicted with anorgasmia from SSRIs, for instance. It's a side effect that patients sometimes either don't mention or don't make the connection, so it is worth specifically asking about it in follow-up review appointments. Moving on then to other particular considerations when it comes to side effects. Well, serotonin doesn't just work in the cerebral cortex. Platelets also depend on serotonin for some of their functioning. So SSRIs can cause problems with platelet functioning and with bleeding, and that is a particular problem for patients in situations where they're on blood thinning agents, for instance. Another potential problem with SSRIs is hyponatremia conferred by SIADH. You don't often see it in adults, but it does arise in older adults and is worth bearing in mind. Another particular problem to bear in mind for SSRIs and SNRIs is serotonin syndrome. The symptoms of serotonin syndrome, which is conferred by having too much serotonin in the intersynaptic cleft, are restlessness, diaphoresis, tremor, myoclonus, and convulsions. It can be caused by inadvertent or advertent overdosing, but can also be conferred iatrogenically. For instance, if you do a very rapid swap from fluoxetine, which is a very long half-life, to, say, paroxetine, short half-life, or sertraline, and ramp up the dose of the sertraline or paroxetine very quickly, you run the risks of giving the patient serotonin syndrome. Moving on then to other considerations, compliance is always worth checking on. Most patients do not take most of their medications most of the time, And a study in America found that a substantial minority of patients prescribed an antidepressant never collected the first prescription. So always worth considering and looking at. Other considerations then, I mentioned that whether an SNRI is an SNRI or not depends on the dose to a degree. Venlafaxine is just another SSRI until you get the dose to 225 milligrams and beyond. It is only when venlafaxine reaches the dose of 225 milligrams per day and goes higher than that, that you get the effect on noradrenaline as well as the effect on serotonin. Worth mentioning with venlafaxine that 225 milligrams is also the point at which you are more likely to get problems with hypertension from venlafaxine, both diastolic and systolic, and it is always worth checking blood pressures for patients on venlafaxine, particularly when the dose goes beyond 225 milligrams per day. Other special considerations then, we're getting into the final lap now, thanks for bearing with me. Citalopram and, to a degree, escitalopram were very popular until considerations about QT prolongation and combining them with medications with a propensity to cause QT prolongation, such as quetiapine or methadone, came in, and that's almost killed them. There is just too much hassle with citalopram and escitalopram nowadays, and most people would consider using other antidepressants as a result of that. Again, particular mention, specific consideration. Sertraline is considered to be the SSRI with the least likelihood of interacting with other medications. So it is the one favored when there are other medications or there are other comorbidities, not just psychiatric but physical, for which medications are being prescribed. And sertraline is considered the go-to medication when there are other drugs in the field or there are other comorbidities present. Tricyclics then, you will see to a degree. They are usually reserved for second or third line. You will be familiar with tricyclics to a degree. Amitriptyline is used for managing chronic pain, but the difference is with the dose. For chronic pain, you'll be looking at doses of amitriptyline of 10, 20, 30 milligrams, probably at night, because it does confer an effect on sleep through its activity on H1 receptors, and that's how it can cause increased appetite and increased weight. Amitriptyline doesn't really have a great antidepressant effect until you get to about 150 milligrams per day. Imipramine has less effect on receptors other than noradrenaline, serotonin, and dopamine, and confers less problems then, but they both have difficulties, particularly with arrhythmias in overdose. Lefepramine is worth mentioning if you're looking for a tricyclic antidepressant that is cleaner and safer than the likes of amitriptyline and imipramine. It is almost as safe in overdose as SSRIs. Okay, I will wrap up at this point, and I hope this has been of help, and we can expand on it in one-to-one supervision sessions. Thank you very much indeed.